Good morning and welcome. My name is Teresa Lee, and I'm Executive Director of the Alliance for Home Health Quality and Innovation. By way of background, the Alliance for Home Health Quality and Innovation is a 501c3 foundation dedicated to the mission of leading and supporting research and education about the value that home health care has to offer to patients and the entire healthcare system. We believe that when we're working with researchers, key experts, thought leaders, and providers and stakeholders across the spectrum of care, we're able to strive to foster solutions that will improve healthcare at home through quality and innovation. The Alliance is also a member organization that serves as a national consortium of home healthcare providers and organizations, all committed to advancing research, education, quality, and innovation in home healthcare. Thank you so much for taking the time this morning to attend our briefing to launch the Future of Home Health project and to discuss home health's role in achieving the triple aim. What is the triple aim? The triple aim is a framework developed by the Institute for Healthcare Improvement that describes an approach to optimizing health system performance. The triple aim seeks to do three things. First, improve the patient experience of care. Second, improve the health of populations. And third, to reduce the cost of healthcare. It's the Alliance's belief that home health care offers great potential in playing a key role to accomplish all three of these goals, especially if we're able to make well-informed decisions in addressing many of the healthcare delivery system issues that our esteemed panel will discuss in more depth today. At today's briefing, the Alliance is so very excited to officially launch the Future of Home Health project, a multi-stage research-based strategic planning initiative, which will engage and involve leaders in the home health community, stakeholders across the healthcare delivery system, and national organizations, including the Institute of Medicine. To mark the beginning of this exciting project, today the Alliance is releasing our white paper on the Future of Home Health project itself. In that white paper, we examined the current role of home health care in America, as well as harbingers of the future of home health. The white paper begins to identify key challenges toward achieving a future vision that appropriately uses home health care to serve older Americans and Americans with disabilities. And it explains the need for the project as a means to develop a clear strategic framework to address these challenges. The Alliance's hope is that launching the Future of Home Health project can be used to ultimately develop information and data that we're going to gather, in addition to collective ideas and input from colleagues, other healthcare stakeholders, and the policymaking community, so that we can develop a solid framework to guide us into a future in which we're optimally serving older Americans and Americans with disabilities, and defining the role and the relevance of home health care in that context. To discuss the role of home health and the need to undertake this project, we've put together an outstanding panel of experts that will speak to you about home health's current role in our healthcare delivery system, challenges that the community faces in delivering this care, emerging models of care that show promise for the future, and describe what the Alliance is doing in response to best prepare us to meet those future needs. Before I introduce our panelists, I would like to thank and recognize the tremendous support from each and every one of the Alliance's members. Without their support, there would be no Alliance and there would be no project. In addition, the Future of Home Health project is extremely fortunate to benefit from project sponsors who have identified the Future of Home Health project as being really critical to helping older Americans and Americans with disabilities. So I'd like to thank those two sponsors today, the Community Health Accreditation Program, or CHAP, and Access Technologies. Now I'd like to introduce our esteemed group of panelists. First, we have Ms. Tracy Moorhead, President and CEO of the Visiting Nurse Associations of America. Second, we have Dr. Al Dobson, who's President of Dobson DeVonzo and Associates. Third, we have Dr. Steve Landers, who is President and CEO of VNA Health Group and Chairman of the Alliance's Board of Directors. And last but most certainly not least, Dr. Tracy Lustig, who's a Senior Program Officer with the Institute of Medicine. Each of our panelists have opening remarks relating to home health care in the context of the future of the healthcare system. Following the panelists' remarks, I will be moderating a discussion among our experts and will give the audience, including those of you viewing via webcast, an opportunity to take part in the conversation. If you have a question and you're viewing via webcast, you can please send your questions via Twitter to @AHHQI with the hashtag FutureOfHH, and we will respond to them in turn. So to get the conversation started, I am very pleased to welcome Ms. Tracy Moorhead.
Thank you so much, Teresa. Thank you all for joining us today as well. It's an honor to be here. I'm honored to be a board member of the Alliance, and I believe the organization is launching some very important work today to really envision the future of home health. I'm going to take a few minutes to talk about the role of home health and how our providers and our agencies can better support the triple aim that Teresa outlined. As she mentioned, I'm CEO of the Visiting Nurse Associations of America. Our members are the nonprofit providers of home health and hospice services across the country, of which there are approximately 3,200, according to MedPAC's March 2013 report. Our members are community-based, mission-driven providers who provide support in the home and who are accustomed to working with all patients, particularly those with significant vulnerabilities and complexities in their care needs. As Teresa mentioned, the triple aim is one of the key goals coming out of the Affordable Care Act. The Affordable Care Act really looked to re-envision the care provided by primary care providers and acute care providers, and didn't fully address the opportunities that post-acute care has to offer. I'm going to take just a couple of minutes to try to summarize this important slide that I think addresses and provides an overview of the opportunities across the care continuum to provide improved population health management support services for patients in their home. As you know, home health agencies and home health providers are currently the only Medicare-certified providers to provide services in the home. There's a significant opportunity for home health providers to improve care outcomes, to improve patient experience, and to help keep healthcare costs down. As we know, traditionally, these providers are utilized within post-acute care services, and that is certainly the definition of the home health service that Medicare uses to determine eligibility and to determine accessibility of these services. However, there are significant opportunities for home health to be utilized to support providers on the primary care side of the continuum as well. If you think about the three buckets of care, you think about the primary care, the acute care, and even the expanding world of advanced illness, palliative, and hospice care. Care for primary care providers is a significant opportunity for our members and our segment of the industry. These individuals, particularly as they age and become eligible for the Medicare program, need additional support in their home to maintain their health status, to mitigate risk factors, and to better manage chronic conditions, to avoid primary hospitalizations or exacerbations of their condition that could cause them to have an acute episode. This is a significant opportunity to support physicians, particularly in accountable care organization models and patient-centered medical home models. And we know that there are many home health agencies across the country who are already serving in these roles to great benefit of those provider models. Certainly, the second bucket is the one that we're most traditionally accustomed to seeing home health services utilized in, and that's support for acute care providers. Acute care and post-acute care services are the traditional bucket for home health services to be provided for various patients. These services really help better manage the transitions of care from an acute episode back into the community, back into their home, and also help support family members as they are bringing folks back into their home after an acute episode. Finally, the expanding bucket of advanced illness care. We traditionally think of hospice or palliative care as something that occurs in the last 2 to 3 days or sometimes weeks of a patient's life. What we're beginning to recognize and what many other researchers and policymakers are realizing is that there's a significant opportunity to better coordinate care and to better support patients and family members in the last 2 to 3 years of life. This advanced illness model is one that is rapidly gaining traction and rapidly creating opportunities for home health providers and hospice providers across the country. We're very excited about the opportunities that we see across this care continuum to better support patients and to achieve the goals of the Triple Aim. However, we need to better understand the challenges that we confront in order to provide these services and to expand the opportunities to support patients and other providers. Currently, there are significant numbers of regulatory opportunities that we believe you'll hear from later on the panel, and that we believe we'll be able to work through in the IOM report that the IOM workshop that the Alliance is launching today, and we're very excited to support that work. Certainly, home health has an incredible opportunity to better support these providers and patients, and we're very excited to be working with the Alliance to help spearhead this work. Thank you.
Thank you, Tracy. I think one thing is pretty clear. This is an exciting time to be in healthcare. Markets are changing. The states are changing. What it means to be a provider is changing. What it means to be in a network is changing. What it means to be a home health care provider will undoubtedly change. What we've done in the past several years at Dobson DaVanzo is put together data, and the data are getting much more powerful. They're getting more timely. They're getting more powerful. And what we've done is we've linked the data across time so we can take an individual and watch that person move across time in the Medicare program. Once you understand the pathway or trajectory of a patient, you start to understand things we just haven't understood well in this country. We actually do a very bad job in this country about care transition and continuity of care. In fact, we do a horrible job at it. And I think that one of the things that home health can do is try to improve that and work with the patients and work with other providers to get the care transitions right, to get the discharge out of the hospital right, and get the patient in the right place at the right time. Indeed, our study was called the Clinically Appropriate and Cost-Effective Placement Study. And the idea was when a patient comes out of the hospital, the patient should go to the right place. It should be clinically appropriate. It should be economically appropriate. And I think a lot of the experiments going on, the CMMI for Medicare, the bundled payments, the ACOs, all the rest of it, at the end of the day, a fundamental cardinal economic rule is that when you change what used to be a revenue center into a cost center, all hell breaks loose. And that's what's going to happen in this country when we get bundling in ACOs. The guys that have value are going to be the winners. The guys that can build the networks are going to be the winners. Everybody else is going to be in a fair bit of trouble. We looked at the case of, and we did some modeling, and we figured that over a 10-year period, you might get 35 to 50, 100 billion over 10 with both care transition and substitution. By substitution, I simply mean high-cost providers or you substitute low-cost providers for high-cost providers. In care engineering, which everybody is working on diligently, that is to say, how do people move through the system? When is the appropriate time to be in home health? When is the appropriate time to be most anywhere? We just don't know now, and we're working very hard on that. We, I mean the country, not Dobson DaVanzo. So that said, we figure that under a certain set of assumptions, the kind of assumptions that people are working on, reasonable assumptions, you can get post-acute care reforms. They can work. But first we have to understand what post-acute care is, how the various parties work in post-acute care, and just what it means to move through the environment. And that's what we as a nation are working very hard on. There's lots of things going on out there, too, that I'll mention that we've highlighted on. The VA, the Veterans Administration, has done some amazing stuff. And what the VA has done is they've taken the people and they have a very different question. Medicare says, can we restore you? VA says, how can we take the glide path of somebody's illness through the lifetime and make it a much better glide path, a much more cost-effective and clinically effective glide path? So if you ask a different question, you get a different answer, and that's what VA has done. And in part what they've done is they've done some amazing things. They've reduced hospitalization by 62%. 62%. They've reduced nursing home care by 88%. They keep people in the community. They use home health much more advantageous. We called the folks that had put that together and said, could this apply to Medicare? Medicare, of course, is a very different program. Medicare is a payer. The VA is both a provider and a payer. So it's a very different environment. But that said, there was some talk of the folks that built the VA program that the kinds of things they did could be transported. They could be transported to the Medicare program. Moving on to the PACE program, there's, I think, the great frontier in this country, both on the data and the healthcare delivery, is going to be figuring out Medicare and Medicaid. Right now, the programs don't talk to each other. They don't work to each other. The incentives are for Medicare to do one thing, Medicaid to do the other, and oftentimes they work at counter purposes. It just simply won't work if we're going to meet the triple aim. And I think the folks that are going to really get it hard are going to get the folks that watch you come out of the acute care hospital, primary care, as you said, acute care hospital, then post-acute care, and then long-term care support services. And we really don't understand the relationship between all of that stuff. I just added your your long-term care support services to your chart. And that said, we got to understand the data, we have to understand the care modules, and we have to understand things we don't even begin to understand. What is home and community-based care? How does it link back to nursing homes? What are the appropriate transitions? Just at that level, never mind all the stuff that this meeting was put together for. That said, I think this is going to be just an amazingly, incredibly important time for the next 3 to 4 to 5 years. Pick your time frame as to how long it will take, but I think we're going to see things we just haven't seen the like of in the last 50 years, let alone the next 5 years. And I think this study is perfect because it puts us right in the middle of this maelstrom of activity, of innovation, of thinking of how to do things right, as opposed to just kind of muddling through, which we've been kind of doing for a long time. So that said, on this slide, I have bundling, I have ACOs, I have patient-centered medical homes, and I have the home health provider. The one message I have to home health providers and to people on the panel, of course, is that we don't know what's going to prevail where. Are we going to have a series of bundles across the country? Right now, I believe we have 160, 70, about 140 of them. ACOs, I saw some projections the other day that 1 out of every X hospitals will be in an ACO, but the X was a big number. Patient-centered medical homes are out and strong. But if you're a home health provider, you're kind of in a very fluid environment. You don't know who's going to control what. And each market is different, each state is different, each network is different, which puts an enormous task on home health to understand their networks, their providers, how they can play through these systems. And I think when we get into the moderated sessions, one of the questions we'll ask is, how can home health step up to the plate and get a lot of things right as they work with other providers to figure out how this system is going to work. On the next slide, I have backwards. There we go. So on this slide, just some basic points I'll make as I close out. There's certainly many opportunities for home health providers to help improve the way post-acute care is provided. There's many opportunities for people that are managing post-acute care to understand better where patients should be placed. Indeed, I think one of the frontiers is going to be patient placement over the next, say, 2 to 3 to 4 years. We have the care tool. Many people out there don't like it very much. It's complicated, hard to use, but it had the right idea. A common assessment across all the settings to which people go. And if you have that, then you have a much better understanding of how to pace your placements. It needs to be quicker. It needs to be smarter, the care tool that is. It needs to be a lot of things, but we'll get there. And many people across the country are developing many tools that do a couple things. They tell you where to pace placements. They tell you how long a person might stay in the hospital. They kind of predict where the readmissions will come from. The simpler, the faster, the quicker the tool, the better. And we're going to have those kinds of things as we work through home health, as we work through other providers, as we try to understand where the patient should be on any given day. Now, this thing about bundling, I'm an economist, so I love bundling, because bundling has the action of, from an economist's point of view, the more things you stuff into a payment, the more control you have over what you pay for. If you can figure out what the it is you're paying for, that is to say the bundle, when does it start, when does it end, what should we put in it, what are the incentives, then you have a lot of power as a payer. I was a regulator for many years. I understand this stuff. I helped build DRGs. DRGs had a very powerful effect. But you got to do a lot of things right, and I think we'll muddle through as we try to figure out how to make bundles work. That said, though, as I say on the slide, clear definition of when the episode starts and when it ends. There's these things called conveners. Nobody quite knows what they are, but a convener basically are the guys that manage the system. They take the risk. They understand. Hopefully they understand where patients should go on any given day. They'll develop a lot of tools. And as they do that, therein is home health opportunity. Home health can be the low-cost provider. If they're the smart provider, the value provider, they get the networks right, they can really thrive under this bundled kind of environment, the ACO environment. If they muddle all that up, they're not going to survive so well. Other people rise to the fore, take their place, and they'll do things like what current home care does. So I'll just conclude with the way I start. Exciting times. I think that this panel can be right on, help sort of think about the kind of things that might happen over the next 3 to 4 to 5 years.
Thanks, Sam. Good morning. Really neat to get to talk to you all this morning and to follow Tracy and Al. I just want to frame in kind of the way I'm thinking about this. We're talking about the Medicare home health program, and really, going back to the start of Medicare, the President Johnson, when the law was signed in, said that Medicare, the signing law reminds us never to ignore untended suffering in a land that's bursting with abundance, okay? And right now, thousands of nurses and therapists and home health aides and other people are working with families that are, and people that are living in the shadows of life. They are going through some of the biggest struggles and hurdles that you can imagine, that any of our neighbors or friends or family members have to endure. And they're helping them find a way. Returning home after having a stroke, learning to walk again, learning to talk again, learning to eat again, dealing with problems that aren't going to get better, things like multiple sclerosis, Alzheimer's disease, Parkinson's disease, situations that are likely going to be with these individuals, chronic conditions, serious conditions for the rest of their lives. And home health workers, home health nurses, they're often that ray of light, that bit of support, that skill, that tenderness, that bit of compassion to help these families and people help themselves remain in the community. So this is really important stuff. Okay, this is, I believe, one of the most important things that we're facing as a healthcare system and as a country, and it's getting more important and more of an issue because of the demographics. Right, by 2030 there'll be over 70 million older Americans. Many of them are going to be living. They're not all going to be perfectly healthy. We anticipate high rates of chronic illness. We anticipate rates of activity limitation, disability, and we want these folks to be able to stay healthy at home, to avoid unnecessary and costly hospitalization, institutionalization. This is really essential both from a humanistic standpoint and from the economics of it. We need this future cohort of older Americans to be the most independent group in the history of the country. And I think that's possible. Now, the current Medicare home health system, I'm supposed to talk about challenges. And there are many challenges that we face in home care. I've seen this as both a physician doing home care, working with home care providers, and now being the president of a home care organization. There's a lot of things that need fixing in my view, and in many view. One is, we've got there's some program integrity issues in the Medicare home health system. We've got certain regions and geographies where there's what would seem to be very aberrant utilization patterns that almost smack of fraud. We have a payment system that is so complex it borders on nonsensical. Quite frankly, it is. You've got 130 different ways to spend $2,500 by checking off about 1,000 different check boxes. We limit services in a strange and arbitrary ways. You have to be, quote unquote, homebound to receive home health services. This means that if somebody is, that has a chronic condition that has brief episodes or periods of time of recovery or fits and starts, peaks and valleys with their care, they become intermittently ineligible for home care services. And that creates gaps in care. People get confused and don't get help all the time. We want to help people when they come home from the hospital. For example, I can think of a patient that been hospitalized 4 times in 6 months. A couple times they tried to set up home care for her. It was a 92-year-old woman who the clinicians were really concerned about. But she kept telling the case managers that she still drives to church on Sundays, and they say, well, she's not homebound, she's not eligible for home care. Well, after the 4th time of being in the hospital, finally it was kind of figured out that she had early Alzheimer's disease, and she really hadn't been driving at all. She wasn't remembering things. And so she really was homebound and needed a lot of help. When somebody finally got out to her home, they realized she was eating spoiled food and didn't know where her medicines were and really needed a ton of help. But instead, our system has people trying to figure out, is this person homebound or not, as opposed to figuring out how can we help. We're going through an era where there's a lot of talk and action on what I call arbitrary payment cuts, group punishment concepts in home health, where really not thinking about how these payment policies are going to impact the talent, the technology, the resources that we have to take care of the boomers. and to take care of the people that we have now. We need to focus our payment policies, in my view, more on value creation and whether or not the services and the organizations help people stay healthy at home and help those families stay intact in the community, not arbitrary across-the-board payment cuts. That's one of the hard parts right now in the home health world that we need to move away from. And other areas, of concern is just the siloed payment structure. I think that's been alluded to, that there's some hope with health reform that some of the new payment redesign initiatives will help with that. I think that there's still a lot of work to be done to make sure that home health is able to help solve those problems, help make those initiatives successful. We still, on the technology integration side, post-acute care, home and community services have not been entirely integrated and interfaced. The waivers and allowances to help hospitals and physicians form accountable care organizations and help people, help manage the healthcare spend. Those same assurances and protections have not been afforded to home health. There's still a lot of work to be done. Now, what our approach is, and this is what, I think the good news is that in this time of uncertainty and of, I think great challenges in home care and also great challenges in elder care as a country, what we're taking the time to do is trying to envision a different and a better future. And that's really what this Future of Home Health project is all about. This is about understanding what are the issues that we face, what are the opportunities for making things better, and how do we basically envision a new and better future for home care, one that can fulfill this potential. I'm reminded of the Eleanor Roosevelt's quote that the future belongs to those that believe in the beauty of their dreams. And my former boss, Toby Cosgrove at the Cleveland Clinic, says that the future belongs to those that seize the opportunities created by innovation. And I think what this project is about understanding and dreaming a better future, and also about understanding what innovations, what ideas might we embrace that are going to create a better future. And then for us mere mortals, we're going to have to somehow distill this stuff into a plan and actually find some concrete steps that we can take as organizations, as a country, to make things better. And so we're excited about this project, about the upcoming workshop that we are going to be sponsoring with the Institute of Medicine. We are enthusiastic about a symposium in the fall that we will further dive into the issues that we identify in the Institute of Medicine workshop. And we'll also be into the end of this year and next year embarking on other research initiatives to better understand the current and future role of home health in the delivery system. So this is a wonderful project. This is very important. It's going to make a difference in the lives of many people that are struggling on a day-to-day basis. And it's a big strategic issue for the country. So I've talked enough. I'll let my Tracy Lustig from the Institute of Medicine finish off our panel. But thank you.
Thank you. I'm really excited to talk to you about the workshop that we'll be planning. I also realized I should make some disclosures about myself, which is, first of all, not only have I worked in aging issues, but in my previous life, I was a podiatrist, and I not only went to people's homes to care for them, but I certainly relied on home health care for many of my patients and wound care and things like that. So I have that perspective. And then I also have the perspective of being a family caregiver for my mother, who had a very brief but intense battle with ALS. And we certainly had to rely on home health care providers. So this really is an important issue for me for many reasons, with many hats. Let me just get my slides here. So just very briefly, for those of you that don't know the Institute of Medicine or the National Academies, or maybe I can dispel some myths about us, the original National Academy of Sciences was actually established in 1863 by Abraham Lincoln, and the purpose was to provide advice to Congress and the nation on matters of science. It was science and art. And although we were established by Congress, we are an independent, nonprofit, nonpartisan organization. And really, we're kind of mainly known in three areas. First is that we're an honorific organization, and so you'll hear where people are members of the Institute of Medicine or other things. And I should take a step back. I know I'm throwing a lot of terms out. The academies were founded originally as the National Academy of Sciences. As time went by and as science developed, we added academies or parts of the academies. So there's the National Academy of Sciences, then there was the National Research Council, the National Academy of Engineering, and the Institute of Medicine was added in 1970. So collectively, we're known as the National Academies. I know it can get confusing. I directly work for the Institute of Medicine, although I work with many parts of the academies. So firstly, like I said, there's an honorific organization. Secondly, what people often know us for are what we call our consensus studies, and this is where you may have heard the IOM says this should happen. This is where we bring experts together and actually issue a set of formal recommendations, and that's one set of activities that we do. In terms of home health, we have certainly done things related and directly on home health care. Improving the quality of care in nursing homes was from 1986. It established the first nursing home standards ever. We would like to think all of our reports have that kind of impact. Some do, some don't. Some of it has to do with timing and other things. We also did a workshop and a consensus report that came out of our National Research Council probably about 5 or 6 years ago on healthcare comes home. It had to do with human factors and how home healthcare works. And so the last area, and this is really the focus for what we'll be doing, or what we describe ourselves as providing a neutral venue. And so we do this in many ways. We have standing forums and other things that I'll talk a little bit about, and then also the workshops that we do. These activities don't lead to formal recommendations. What we really see ourselves doing is, again, providing that neutral venue to bring together government, industry, academia, consumers, professionals, encouraging them to come together, bringing people that might not normally come together or might not have a way to come together, hear from each other, and try to work together on a variety of topics. Oops, I'm using the wrong thing here. So I run our forum on aging, disability, and independence. Our forums are ongoing activities where we bring, like I described, people together 3-4 times a year, come together on topics. They decide what they want to learn about, what they want to, speakers they want to bring in, papers they want to commission, doesn't issue recommendations. It's really a way for different stakeholders to understand each other's points of view better, learn from each other, and figure out how to work together better. This particular forum stems from 2 of our previous consensus studies. I'm hoping you'll be familiar with one or both of them. The one on the left was Retooling for an Aging America. That came out in 2008. I actually directed that study, and it was really focusing on how prepared our healthcare workforce is for the aging of our population. The short answer is we're not. I will also say that the IOM pretty much put out the same reports in 1993, 1987, and 1979, saying that aging was one of the biggest challenges this system was going to face. The problem in 1979 was we were yelling that this was going to happen about 50 years from now, and when we put out the report in 2008, we said, guess what, 2011, first baby boomers turning 65, so it got much more traction. In terms of home health care, that report, I would urge you to look at it. It really talked a lot about not just that our population is aging, but we're living longer, living healthier, but also living with much more chronic disease, disability. The other big difference is we also have less children, and we also are not living near our families anymore. So while family caregivers are an extremely important part of long-term care, we also really have to think about people that don't have that family around or at all. And then a big focus of this study was also how well trained are the workers who are going to be going into people's homes, and we're going to need even more of them, and how are we going to train people and prepare them for this role. This forum, Teresa Lee came and has been coming to some of our meetings and working with us and talking to us about how home health is so important to both people aging with a disability and people that are aging into disability, and that's how we frame our forum. And so we worked together to come up with a statement of task for this workshop that we're going to be holding. The forum itself is sort of being, in a sense, hosting it in name, but this is really, it's sponsored by the Alliance. And how our process works is first of all, we work very hard at defining a statement of task, and we've been working several months on really ensuring that the focus is right. I would say that knowing what you want to do is really important to get that down right from the beginning. And I'll talk a little bit about what that statement of task is. Our next step that we'll be working on very shortly is putting together a planning committee. Our process works that we'll gather somewhere in the range of 6 or so people that have various areas of expertise related to our statement of task, and they are really the people that will plan the agenda for this workshop. And we're envisioning this as a big 2-day workshop, and so they are the ones who will really put the agenda together, identify speakers, and make the day something really great. So they will work hard to put the agenda together. We'll hold a workshop. After that, we draft a workshop summary, we call it. This is, it's not a transcript, so it's not a word-for-word thing, but it's also not something like 2 or 3 pages. It's really a document that is, we're hoping will be hopeful to people that couldn't be there or were there. And it's a summary of what was discussed, what were maybe some of the themes, what people said. It will not come out with formal recommendations, but our workshops, we see them as a way to explore a topic, identify areas maybe that future work might be done around, and so that's how that goes. Like I said, the summary will reflect the discussion. We do ensure that it does go through a formal review process, both by people who were at the workshop and who weren't, to make sure it reflects the discussion and that it also is readable to people who are not there, because we want it to be a usable document. And again, I always emphasize that this won't come out with formal recommendations. And so finally, the workshop itself that we really wanted to talk about, this is just a very simple overview of the statement of task that's meatier than this. But first of all, maybe obviously we're going to go over really what's the current state of home health care, give a good overview to that, and then start to explore innovative delivery models, like we were just mentioning, really kind of what's happening, what are more cutting edge things, where is it going? And then I think spend a bulk of the time trying to think about how we can best facilitate the future role of home health care. How can we really use home health care to its best advantage, and looking at all the different needs that home health care has. So are they infrastructure? Is it workforce? Is it technology? Research and measurement? Policy reforms that might be needed, and how do we communicate better about home health? And so I think I will leave it there and open to questions.
Fantastic. Thank you so much to each of our speakers for their introductory remarks. I'm going to be just asking a few moderator questions. I want to remind everybody that we will have an opportunity for a Q&A, both from the audience in this room and also from those of you viewing via webcast. And again, if you want to ask a question via webcast, you just want to tweet those questions to @AHHQI using the hashtag FutureOfHH. So the first question is for Tracy Moorhead. The question is, what makes home health providers and professionals uniquely positioned and qualified to facilitate achievement of the triple aim?
Thanks, Teresa, and thank you to the other panelists. What a great overview of some of the opportunities and challenges we have, and I'm very excited about the IOM partnership. As you outlined the triple aim earlier, we know that it really focuses on patient experience, on patient outcomes, and on cost reduction or cost savings. And I think if we look at this from 2 different perspectives, we can see the significant opportunities here. First, let's look at it from the primary care perspective. Certainly, we know that having support outside of the physician office is critical to preventing unnecessary emergency room visits and unnecessary hospitalizations. Improving the patient experience by providing intervention and support in the patient's home can certainly help the patient stay in their home and avoid these unnecessary hospitalizations. It can help them better manage their conditions, and certainly the cost savings from unnecessary hospitalizations or from avoided emergency department visits can certainly contribute to improved program management as well. On the acute care side, it is very similar. Certainly we know from AARP and from other surveys that patients prefer to age in their home. They prefer to be cared for in their home when possible. Their rates of satisfaction with home care exceed rates of satisfaction with other post-acute care services. Also, with regard to quality outcomes and health status outcomes, CMS's own home health compare tool indicates that there is a significant level of quality and health status improvement achieved through home health care delivery, home health services. And finally, with regard to cost, if you think about the 4 post-acute care settings, home health is certainly the least expensive of the 4. We're very excited that the care tool that Al was discussing earlier has great potential to improve the referrals to home care and to really help ensure that the patients who are appropriate to receive care in their home can do so and can allow the professionals who are providing those services to help improve achievement of the triple aim.
Thanks so much, Tracy. My next question is really for Al Dobson. And Al, you talked a little bit about bundling and as an emerging payment model for post-acute care and different approaches. I'm wondering if you can do 2 things. The first is to maybe talk a little bit about bundling as a means toward reform and what can be learned from the established bundled payment models, but then also talk a little bit about what individual home health providers should be doing to prepare today for the future.
Bundling is a larger unit of aggregation for the payment system. More things are put into it. It gives the payer more power. We've got some experience with the last couple of years as a nation. We've been working on bundling. I think there's about 140 bundles out there. 70 of the bundles have the hospital included in the bundle. The other 70 are only for post-acute care. As I said, the first thing you have to do is define the bundle, but I think some of the more interesting things are as follows. The first is networks. Folks are struggling to understand networks. For instance, we looked at 3 hospitals in a state. They had 214 nursing homes that they were associated with. Hardly a manageable network. We worked with other folks on the post-acute care side. How many home health agencies they deal with? Many, many, many. And I think that as people start to do their networks, there's going to be a market transformation of what the industry looks like, consolidation, the kinds of things. And I'll talk a minute about how the counter to that is, because obviously if you're out there in the industry, consolidation can be a rather ugly fact. But that said, network is a very important thing, how it's put together, how it works, who's in charge, this convener role whereby the convener will put together the networks, then distribute payments. All are going to they're fluid now. We don't really understand how they'll evolve. But what I've seen to start with is there's going to be enormous pressure on the number of units out there that are in networks as people try to streamline their networks. Secondly, value. How do you select who's going to be in your network? Has to be value. You have to be a valued provider in your network. You have to be efficient. You have to be clinically efficient. You have to be clinically effective. If you're not those things, who would invite you to the party? You're not going to be part of a network. So I think it puts enormous pressure on each and every home care provider out there to be better than they are now, to be better than the other guys, and to be better than the other PAC institutions as well, SNFs, IRFs, and LTACs. That said, I think it's really important then that the network formulation and people as they vie to become part of those, they'll think their way through that. Another thing that's coming through here like a freight train is freedom of choice. The patient has, under Medicare, under Title 18, the freedom of choice. That these bundles do not forego freedom of choice. Freedom of choice is still there. So you're a convener, you do your actuarial work, you put your network together, and then all your patients decide to go to the guys that don't have value, et cetera, et cetera. It puts the whole thing at some risk, but it also says there's going to have to be solutions that are bundled will just crater. It just simply won't work. So what we're going to have to do is have network formulation, we're going to have value, and we're going to have a way, I think it's called soft persuasion, where you say to the patients, if you do X, we will do Y for you. That's legal, it's appropriate, and maybe in the long run it might provide much better patient care. But clearly we're going going to see a lot about how that works. Then the what is it, the what do we actually do in a bundle has yet to be defined. What is continuity of care? How is it right? How do you measure the patient when they come out of the hospital to know where they might go? This care tool, which we've mentioned several times on the panel. Those kinds of tools are going to be absolutely important to understand how we make the bundles work better. Now, as we think from the other side, if you're a home health provider looking up, I think it's just the flip side of many of these. You have to show value. You have to show that you're efficient. You have to show that you can reduce readmissions, because that's what you're going to be asked to do. You have to be a part of the care community. There's a whole lot, care continuum. There's just a whole lot of things you have to do as a home care provider that people really haven't asked you to do. The one thing we've learned about bundling that's most impressive, most interesting, most something, bodacious, call it what you like, is that we really don't get as a country, because of the way we paid for health care, too much about what happens outside of your four walls or outside of your institution. You're a home health provider. Well, what's the linkage to a SNF? What's the linkage upstream to the hospital? How does the patient move through the community to the primary care physician? That one home health care should have pretty good. But by and large, the people that manage post-acute care don't know what it is, but at the higher level. Obviously, we're good in our silos. But as we move upstream and we're trying to manage across the silos, we don't have a clue how people move from home health to skilled nursing, maybe to rehabilitation, whatever, or when they should come out of rehabilitation to home health. We just don't know that. We've done episodes where we see people in a month moving 30 times. Makes no sense at all that people should move that much. Indeed, about half the patients move 3 or 4 times. They come out of the hospital, 60 days later, they've had 4 different landings. That kind of makes sense between physicians, home health, and rehabilitation. But 5, 10, 15, doesn't make any sense. But we see it in the data, and we know it's wrong. We just don't know how to fix it. But I think that as people take responsibility for bundling, they'll certainly figure out how to fix it. And the home health care folks will have to be part of that process to understand what fix it means, how to keep people from transitioning unnecessarily. And when they do make the transition, that's when patients are most vulnerable. We have to help patients as they move through the system, and home health can be very good at that as they move people, because they're out there, they're seeing the patient, they're sort of live on the site with the patient, understanding what the patient's needs are, and I think home health can really do that. Finally, I think that home health has to get the story out. The story's quite good. The story is home health has enormous capabilities. It has a lot of flexibility. It has the right price relative to the competitors. It just has to get the story out. And some of the downsides, the fraud and all that stuff, we got to get, home health has to go by that. But I believe that that's underplaced. There's a lot of initiatives, legislative initiatives to take care of that. I see that as something not to worry about so much. It'll be taken care of because the industry really wants to take care of it. Once we get past that hurdle, then the hurdle is how you handle the value, how you handle the discharge planning, how you handle all the rest of it. Home health should be very well positioned to take that on. Then I'll end on one final point, and it's a really hard one, and that is the consolidation issue. It's anathema to providers to say that might be half of you left the next day. So you just can't have that. You have to figure a way around it. Maybe one way is consortia of home health providers. There's got to be ways that the home health care providers can look as one and look mighty, as opposed to little individual units that are each fighting for value with the consolidator or the convener. So I think that home health has some organizational, systemic kinds of things to worry about, as well as the technology and all the things we've seen on that slide. Home health is going to have to figure out how to be competitive, how to be organized, how to appear big as opposed to small. And they're going to have to do that with the conveners, because the conveners are going to ask that. They're going to say, who's going to provide me value? And they're not going to look to 50 anythings. They're going to look to a couple. So there's got to be a way that home health can organize themselves to look as a couple, look as a few, look strong, look powerful, do all the things clinically and economically, but also organization. I think we're going to see some amazing kind of responses to bundling, because bundling is going to force it and force it hard. The incentives are very powerful. And when there's risk, there's opportunities. And I think there's a lot of opportunities here, but people are really going to have to pay attention or they'll get swept aside. Thank you.
Thanks. My next question is for Steve. And I'm wondering, Steve, if you can draw from some of the work that you've seen in the family medicine community and as a geriatrician, and talk a little bit about how you think that the home health community, patients in the healthcare system, will benefit from the Future of Home Health project, and talk a little bit about both sort of the near-term and the short-term challenges that you see.
Thanks, Tracy. So the Future of Home Health project, really the idea is to really, for us to look in the mirror about what we're doing in home health, and also learn from some of the key groups that we work with, physicians, hospitals, payers, the advocacy community, to try and figure out how can we maximize our impact? How can we make a bigger difference in the future and solve some of the problems that we're facing today? Some of the inspiration for this actually came from an effort about a decade ago called the Future of Family Medicine project that Teresa alluded to. And really, that was a time where the primary care physician community, the family doctors, were trying to figure out, what's our place in this healthcare system in the future? It seems like what we're doing isn't valued. There's a lot of conflict about what we should and shouldn't be doing and what our role should and shouldn't be. And some are saying we're irrelevant, and others are saying we're incredibly important, and it's confusing. And what they embarked on was a project called the Future of Family Medicine Project, where they did research-based strategic planning, and they tried to learn about themselves and about the world that they were working in and would be working in. And they came up with something called the new model of care and the new model of primary care. And actually, that new model of primary care ultimately was rebranded as the patient-centered medical home. And it became the beginnings of a new framework, really for our country, for our payers, for the Medicare program, for others to think about primary care. Now, if we're as successful with this project as the Future of Family Medicine project was, it would be a wonderful thing. I think that we have a chance to do that. I think that we do need a similar exploration and re-envisioning of what the future model of home health should look like. I think that there are a lot of challenges to getting there. I think that can you get all the people around the table and get participation? I'm excited by today to see the enthusiasm and interest in our kickoff. So maybe we're headed down the right road there. I think that there is. We're just digesting a lot of health reform. I think that there's been a lot of change and a lot of initiatives, and I think that we need more to get it right in terms of home care and elder care at home. I do agree with the idea that changing payment systems, bundling payments, that will put incentives in a better direction because of the narrow and rigid policies that the different provider types work within, like home health. We do run the risk of just sort of rearranging the deck chairs on the Titanic if we don't really look at the clinical structure, we don't look at the payment model for some of these provider types alone, and get that better aligned with the future opportunities and the future potential. So I think that there's some areas here where we've got an uphill battle, but this is really important. I think most people, you look at around the kitchen table or family events, people, most people have been affected by serious chronic illness, serious disabling illness and conditions. They understand how important this is. I think the public wants us to get this right. I think the baby boomers want us to get this right. So, I think we've got a lot on our shoulders to try and work through. But it's a big opportunity to try and re-envision a better model for home health. Absolutely.
Thank you. And this last question from my moderator questions is for Dr. Lustig. And you talked very eloquently about the IOM and the Forum on Aging, Disability, and Independence. And, what Steve just described is, the challenge that we're facing. I'm wondering if you can talk just a little bit about how the IOM Forum on Aging, Disability, and Independence, how it tends to look at these matters and sort of what are the emerging issues that you're hearing about, and how does the Forum analyze them?
Sure. Well, as our name itself says, one thing we always say in the Forum is independence is really the focus of what we're talking about. Again, whether you're aging into a disability or with a disability, what are the things people need to live independently? Because, as was said, we know that's what people want. That's what they want, especially the baby boomers. They're a different generation than the ones we've worked with before in a lot of ways. We have spent, we've had a couple of workshops already that have come out of the Forum. One is on financing of long-term care. That's a big concern. What's the individual's responsibility? What's the government's responsibility? What's the private sector's responsibility? Because this is a big issue. We've also looked at technologies that can keep people independent, and that's in healthcare, but it's also in working, keeping people working, keeping people in their homes. Again, that's what they want. And then I'd say the third area that's big for me, especially as I talked about with the previous report, is the workforce. When we released our report on retooling for an aging America, my chair said, a lot of people spend time talking about the Medicare Trust Fund and whether it'll be funded. And he said, and that's a problem. But even if it's fully funded, if there's nobody there to provide the care, it doesn't matter. And that's something that I always, I think workforce is one of the key issues that's often overlooked. And I certainly don't have to tell all of you who are in home health care, not just issues of workforce, but turnover of direct care workers and quality of care and training, like I mentioned before. So, and the way the forum works is kind of like we've done here, is they talk with each other and they identify problems, and then we try to have workshops about them as ways to further explore and discuss, to drill down to what are things that might facilitate, like we said, facilitate the future role of home health care.
Thank you. Now we'd like to see if there are any questions here in the room and on the internet. First here in the room, any questions?
Hi, Grace Whiting from the National Alliance for Caregiving. I really enjoyed the presentation, especially the comments about the changes in family caregivers over time and their, as the population ages, there'll be less caregivers to provide support in the home. One thing I'm interested to know about the project is, especially for those who are caring for Alzheimer's patients or those who are at later stages of chronic disease, it can be a very hard burden on a family caregiver to care for somebody in the home, especially at those later stages. And then you have, in addition to that, family caregivers coming out of pocket to provide support to these persons who have chronic disease. So to what degree will this model incorporate that perspective, the patient perspective, and what's possible for the family to do in the home, especially for someone, they have multiple comorbidities, they have multiple chronic conditions. To what degree is that patient and family going to be part of the care team under a new model of home health?
That's a great question. I'm going to direct it to Tracy Lustig first, because it was your comment that triggered the question.
Yeah. First thing I would say is one of the big things that came out of the report that I worked on that I still hold very firm is that when we say the healthcare workforce, we mean the professionals, the direct care workers, the families, the patients themselves. They're all part of the healthcare team, and we need to always remember that. For this particular workshop, it's always dangerous to try to bite off too much in any project that you do. So if we try to cover the gamut, we're not going to do well to any part of it. This workshop, I didn't have it up on the slide. It's a bit more focused on Medicare home health care. So it's going to be more of the formal part of the delivery of home health care. Although I would say those issues are so intertwined, there's no way that the words family caregiver or that those topics are not going to arise. But just this type of thing that you're bringing up are the issues that the planning committee, when we put them together, they are the ones that will really sort of struggle of like, well, what's in and not what's out, but what do we really need to focus on for the purpose of this statement of task?
Thanks, Tracy. And the other thing that I would only want to point out is that when we talked with the IOM about the statement of task, we talked about not just the core home health benefit, but the question is, how do we get from the current state to a better, brighter future in the context of best serving older Americans and Americans with disabilities? And a key consideration in trying to get to that brighter future is, what are the infrastructure needs? Among those infrastructure needs, or what do we need to do in terms of supporting caregivers? What do we need in terms of housing, nutrition, and meals? It's so very multidimensional, and we can't be looking at a silo at home health. It's very broad what's needed in terms of really enabling independence at home. Any other questions here in the room? Okay, right here in the front row.
Thank you. I was very appreciative of Dr. Lander's remarks. But before I get into that, I just want to say I appreciate this effort very much because it's very positive. It's a looking forward. It's not that we have to turn away from fighting today's battles. There's a lot of battles today. but at least it's standing back and moving in a positive direction.
The work, I don't know about us administrators, but at least what our employees do in terms of helping people at home, it's pretty pure and good. You know, it's about as basic a thing that a society should be doing as there is in terms of supporting people on the fringes of life because of illness and disability and other things get by, helping family caregivers be successful in their work with their loved ones. This is really basic, important stuff. And on the other hand, on the other side of that paradigm, you have some problems. And I look at, I believe that if there's critics, if you will, I think that some of their concerns are certainly based in a legitimate, concern about whether things could be better, right? We do have funny things about the Medicare home health payment system. Why if you do 4 visits, you get paid this, and then you do 1 more visit and it boosts up to another level? I don't see from a medical standpoint, as a clinician, I don't see the rational clinical explanation for some of the aspects of the payment system. So what I like about the approach that we're trying to take with the Future Home Health Project is to let's be open-minded, about what are we really talking about, what's the opportunity, what's the importance of this. I think it's incredibly important. I don't think any members in the policy world that care about healthcare wouldn't acknowledge the importance of helping these individuals and their families succeed. And at the same time, let's also be open about there might be some flaws in the way that we're going about this, and there might be some ways to make it better. And so hopefully we can come up with some ideas and a bit of a framework. I think that's a little ways off. I think the initial work we're doing is more exploratory in trying to better understand the different things going on, and let's try and figure out something better. Let's have a future where people can get better, higher tech, higher touch care at home. That the baby boomers are the most independent generation in the history of the country, and that this moved care home and this improved home health not only reduces the burden, expense and suffering-wise on families, but also is at a better deal for the government. Let's figure that out. That's what I'm hoping we can work on.
Here, and I think that I've been pleased to see that there's enormous support for that desire to come to solutions and to really identify a true model for helping those who are frail elders, who are growing into becoming frail elders, and helping those who are burdened by disability, and all of those involved with them. So I want to thank everybody for attending here in person as well as via our webcast. I know that many of you have tweeted questions via Twitter. We promised that we're going to be responding. And if you had a question here in this room and you didn't have an opportunity to have your question answered, I hope that you'll come and approach us. This does conclude our panel discussion. Thank you so much for attending. The Future of Home Health White Paper that we are releasing today is available on our website. That's www.ahhqi.org. You will also find the slides that were presented today and other materials related to today's event. We invite all of you to not just continue to track our project as it goes along this year and into next year, but please do reach out to us as the Alliance. My contact information is on the website. You can tweet me, you can call me, you can email me. Our doors are open. I absolutely want this to be a collaborative endeavor, and I look forward to working with all of you. Thank you.